I'm just going to test real quick to make sure that you guys can hear me okay. Can you hear me? Can you hear me? Can you hear me? Just double checking. Can you guys just give me a heads up whether you can hear okay? Thanks, Chris. Thanks for letting me know you could hear me. I just wanted to make sure that it was loud enough on my side. Just going to give people a few minutes and then I think we'll get started. All right. Yeah, I think it's about 11 o'clock, so we'll probably get started if people are okay with that. I think most people can hear me okay. You can just make a comment in the bottom if you can't. I just want to let people know. So I'm Steve Pergam. I'm the Infection Prevention Director at Seattle Cancer Care Alliance, and one of the faculty members in infectious disease sciences in the Vaccine and Infectious Disease Division at the Fred Hutch Cancer Research Center. And just set up this Facebook Live to be able to answer some questions that people had about coronavirus, specifically targeting our cancer population, and wanted to give an opportunity for people to have specific questions that we could answer. But I thought maybe I'd start with a little bit of a review of kind of what's going on. So many of you know in Seattle, there's been a large um, effort put to keep coronavirus at bay. And a lot of us have been spending good proportions amount of our time working on coronavirus prevention. So both my colleagues at the University of Washington in Seattle and my colleagues at Seattle Cancer Care Alliance, my colleagues at Harborview Medicine, colleagues at Seattle Children's, and others have been spending weeks in preparation and in dealing with our first cases that have been coming in. As time has gone on, we have seen an increase in the number of cases that have entered um, into the Seattle hospital population, particularly targeting in the north. It began in Snohomish with Evergreen Hospital, where they have really weathered the early storm. And then additionally, we've started to see cases that are coming in the door in the university system. Both at Harborview and the University of Washington, we've seen additional cases. In terms of the cancer population, we've also seen cases that have involved our patients. But it's really hard to get early data just because it's been such a wide variety of patients and a wide variety of therapies that they're receiving. So sometimes it can be a little bit challenging to know exactly what the outcomes will be. But in general, we worry that cancer patients who are more immune suppressed and have other comorbidities like heart disease and lung disease might be at more risk for developing complications from COVID-19. So as a reminder, what is COVID-19? COVID-19 is a novel coronavirus, probably animal-derived, is what the data suggests that it's originally from a bat, probably had an animal intermediary. Unclear what it is. There's some thought that can be the pangolin and some others, but it's unclear exactly what. Likely started with an exposure in Wuhan, China, and then spread throughout the world very sort of methodically. We had our first case here in February, and really going back in time, looking at this, it looks like it's been in our system in the Seattle sort of metro area and in Washington State for quite some time. We were lucky because we had colleagues at the Seattle Flu Study, and we had colleagues at the Fred Hutch who were experts in looking at genomic analyses and could identify some early cases that suggested we had early community transmission. We also had Frank Rieto at Evergreen, who is really a brilliant and astute clinician who was able to identify an early case. And so by working through all these different processes, we were able to identify some issues on our side that where there were some patients that were positive. And so that really was able to get us all to rally pretty quickly to get our incident command centers sent up. We had our UW virology colleagues who had already developed a PCR assay, which allowed us to get testing strategies up and running. And I think what really helped along this way was really the community coming together, both from a research side, from a clinical side. We've shared protocols, we've developed policies very quickly so we could address a lot of these complications and be ready for patients coming in the door. I also really want to call out Mayor Jenny Durkin and Governor Inslee, who've been, I think, really strong leaders in their ability to sort of say, let's put patient safety first and hospital healthcare worker safety first, and really did a lot of active work to limit to really amplify social distancing within the community. I think that's helped to slow the speed of the progression of disease and number of cases that are happening here. And I think it's been very beneficial from a hospital standpoint, but we all expect that there'll be additional cases that'll be continuing to come in. Estimates for the Institute of Healthcare Modeling, I think it's IHME, I'm probably speaking their name incorrectly, but it's IHME. You can go to their website and see sort of what the initial modeling predictions are. And those early modeling predictions suggest that sometime in sort of mid-April is when we can expect to see the largest surge of patients. And so I think all the different centers around are really working towards preventing and protecting our population. So just a reminder, people, if you have questions, just post it in the book down below, and hopefully I'll see those. I saw one that just got posted, so I will try to address that. So looks like Bridget asked, my child is 19-year-old post-BMT from Hutch in 2001. Congrats that they're doing so well. Is there more of a fear, even if they've been relatively healthy ever since? Yeah, I mean, I think some of the questions that have come up from long-term survivors is, are we still at risk? The good news about really long-term survivors who are that far out is the assumption is that their immune status is much better than it had been in earlier time frames. And so I think someone like this is in a situation where someone who's had a prior transplant in the past should still be very cautious. So I always indicate that someone who's had a bone marrow transplant, they're always a bone marrow transplant recipient. And so I think social distancing is important. A 19-year-old child who's that far out from a transplant, I think it's probably unlikely that the risk is substantial, unless they've had other issues, like they've had complications with routine infections, or if they have ongoing graft versus host disease, which is a complication that can happen after transplant. Also as important is if they remain on immune suppression. And if they've been on chronic immune suppression, then that risk would also potentially go up. So important issues to think about as you're sort of walking through this process is to consider what therapy your child is on, or your loved one is on. And what you might do, Bridget, is you might reach out to the folks at Children's. You might reach out to the former bone marrow transplant teams that have taken care of your son, and really get more information about how that might be helpful. Because my sense is that the risk is a lot less than it was when he was in the early post-transplant phase. But depending a lot on what the complications and issues are afterwards would be really important. Data does suggest from China that people that are cancer survivors are at increased risk. But again, most of the cancer survivors that I've seen in their data has been older patients with solid tumors, and there's very little information about BMT. But it's a really good question. And Bridget, I just want to point out how proud we all are that your child is doing so well. It's always really wonderful to hear good stories that someone's now basically 19 years old after a transplant. So I'm sure my children, my children's colleagues are excited to hear that too. So that's great to hear. I think Jennifer asked about a son who's on Hizentra because of a B cell deficiency after his bone marrow transplant. At which point will antibodies start showing up in blood donations? Yeah, this is something that the blood centers are really looking at very closely. So A lot of the blood donation centers and the blood banks in the country are really beginning to put together protocols to assess this more closely. So our expectation is once a serology assay is more readily available, and there is one now that's FDA approved, that will become an easier process to identify. The advantage there is that we can identify potentially patients who could give convalescent serum, where you take serum from the blood of those people and give it to them to try to help prevent complications after people are infected, or potentially to give collections where you would do something called an intravenous immunoglobulin, where you collect immunoglobulin that has high titers against the particular virus. And that might be helpful for patients that are in situations at high risk. And so you could use it as a prophylactic therapy, meaning you give it ahead of time, help prevent them from getting COVID-19. So I think there's a lot of interest in looking at that. Certainly, there's a lot of interest in serology because we'd like to know who's been infected and who hasn't, because knowing who has and who hasn't makes it a lot easier to figure out where you send people and whether they can go back out in the community for the economy wise. It's an important piece too. But it's a good question. And just key, Jennifer, for your child and I guess your son is to really be sure that you do that good social distancing. Really washing your hands well. I think it's really important as you're going out and touching surfaces when you go out in the community. And please give him our best and keep him safe as you can. If questions come up, make sure you talk to your local physicians there about them. Tam, how much more contagious is COVID-19 compared to flu? So Tim's got an interesting question. I think one thing that's challenging is always when you're looking at these novel viruses. We know that many people within the system can be potentially. It's different than flu, where we have prior existing some existing prior antibodies that probably provide some protection, um, and vaccines really help in a large way. So if you've been um, if you've been vaccinated, your chances of getting this is a lot less. So we can modify what's called the R naught, or the ability of one person to pass it on to multiple people or number of people. So an R naught, a value would equal, this is a layman's terms here, but one person, if you have an R naught of one person would transmit it to one person. Um, and in some situations um, that would be an R naught of one. But let's say an R naught of 5 would mean I would have one person who's ill. If everyone was potentially at risk, I would give it to 5 people. Measles, as an example, if you don't use vaccines, has an R naught of 18. So one person can infect 18 people if they're susceptible. But because of vaccines, we don't see that happen. In COVID-19, the ranges can be anywhere from 2.5 to 3. So it's quite even up to 3.5. So it can be quite a wild range. But importantly, it's higher than flu. And so we know that it's more contagious. And part of the reason it's more contagious is probably the virus, how it works. It's pretty sticky. It has the ability to spread by touching surfaces like flu does. And indifferent to most flu strains, we don't have a vaccine, so it's harder to stop that spread. The other thing is that everyone is susceptible. And so unlike other viruses where there's maybe some pre-existing protection, your immune system is used to seeing flu on a regular basis and you have some ability to fight it. This particular virus is absolutely brand new and different. And so it's one thing that our systems have not seen and don't have the ability to respond to. So I think it's more contagious because of the way the virus works and the way the virus interacts with us. And we know that it causes high viral loads or lots of virus in the system, so it's easy to transmit through that mechanism. And additionally, we think its ability, because of a population that's basically never been exposed to this before, it just makes it easier to transmit. There are some thoughts about, whether it's shed asymptomatically. I think there's more emerging data that is true. We don't know how much of the spread of these infections is related to that particular piece. We think the primary mode of transmission remains amongst symptomatic patients because of coughing and sneezing. That's the virus's main modality for transmission. We spread more respiratory droplets that way. People then breathe in and can get infected. And so there's clearly evidence that is a the primary method. But I think asymptomatic shedding and asymptomatic infection does occur, and it probably has some role in infection too. So that combination of a couple of different things probably makes COVID-19 a little more difficult. But it's a great question, Tam. Sierra, you've asked a really interesting question that I think is really difficult, and she asked, is it airborne? Um, Airborne's really difficult. It's interesting how there continues to be debate amongst a number of different groups about this. The WHO is pretty firm in their decision that this is not an airborne virus. And there's been a lot of debate. There's people on both sides of the fence about this. I think it's really, it's pretty clear in terms of the way we've been seeing things on our side that we have not seen evidence of airborne infection where an individual who had COVID-19 spread it to numerous staff members and a number of people were infected. It's just really difficult to document this. And I think over time we're going to learn more about this. It's a difficult question to answer. I wish I could tell you a 100% solution, but we really have been treating this, though, as its primary mode of transmission is droplet. What we worry about are airborne procedures that we do. So if somebody is undergoing endotracheal intubation where they need to go on a breathing machine, or they're having a procedure where that's producing excess respiratory droplets, then we do protect staff to be sure that that airborne transmission doesn't happen. But in a normal situation, we've been focusing on droplet and contact precautions, which is typical for most respiratory viruses. And so it's a challenge. I'm not sure there's a consensus. I think there was recently a Science article that suggested that there's still this debate in between. But I think we've had success with our modes of prevention, and we feel comfortable with that. So I think that is still out to debate, and there's still going to be people on both sides of the fence. So I'm sorry I can't answer that better, but that's a really tough one. I still feel like the way we've been treating it is a droplet precautions primarily, with airborne for specific procedures has really been the approach that's worked the best. Melissa is asking about, do you believe the intensity of exposure to SARS-CoV and the infectious dose is related to severity of symptoms, even in healthy patients? Yeah, Melissa, there's, again, this is an area that's been really intriguing that people are trying to get better answers to. There's a thought that maybe people who have really extensive exposures with a high amount of virus tend to get more opportunities and potentially more complications from these a SARS event. I think the jury is still out somewhat about this. We just don't know. We haven't had enough cases that we can track and really have viral load data to be able to say. And generally, the patients that are infected that we've seen so far that are published in the literature do suggest that a lot of those individuals are quite that have quite high viral loads. So I'm not sure how we would really identify that, and it's hard to know. Maybe it's the route. Maybe people who get it infected because they get a droplet in their eye is maybe less at risk than somebody who gets it through the mouth or the nose. We just don't know, particularly through that mechanism and how viral load plays a role. But I think many of us are suspicious that that could be true. So can't answer that better than there. Adrian asked, does Fred Hutch offer opportunities for a master's leading to a PhD in cancer pharmacology? Not that I'm aware of, but the UW has a really strong pharmacy program, and there are PhD programs that include pharmacy, PharmDs that can actually do work in research. We've got an Australian fellow that's coming, who's doing his PhD, is going to be working with our group in a few months. So yes, it's possible. I would just reach out to people in the division that you think are interesting that you'd like to talk to. Kathleen is suggesting, she said her son is 20 years post-bone marrow transplant from a sibling donor, chronic low-grade GVHD, gets a lot of sinus infection, and is pretty healthy otherwise. Any extra concerns for him at this time? I guess it depends. Low-grade GVHD probably means he's on some immune suppression, so I think being a little more cautious with him than most others is important. I think particularly for, I don't know how old your son is, if he's in his mid-20s or if he's in his 30s, it's important to discuss really it's really important to just really discuss with him the issues of social distancing, washing his hands. And, I think, again, if he develops symptoms or he has issues, really important to make sure you um, that you reach out to his healthcare provider and talk to him if he has symptoms to get him tested. Um, Key pieces are, if he develops symptoms that are sort of consistent, so things like what we call amnesia, or the loss of a sensation, you can't smell, or you lose your sense of taste. If you have a cough, you'll hear me cough occasionally. I don't have COVID-19, I've been tested. If you have shortness of breath, if you have fever, those would be things that definitely are kind of the big ones, but there's some other interesting information that's out there that can be potentially at risk. And so if he has symptoms that are kind of like a normal respiratory viral symptoms, then make sure that he is um, seen, or you talk to his doctor about it, and really just educate him about social distancing. Really important, and to be washing his hands. I just have hand sanitizer everywhere, so anytime I walk in a house, I deal with this all the time. So I'm not exposing myself to different things. Um, Nick was asking, I mentioned on Twitter that the U.S. coronavirus task force needs to be putting medical experts in the forefront of its response. Can you expand on why that's important? Yeah, I think, part of what's been challenging about seeing the U.S. response is I guess I'm a little frustrated seeing a lot of political discussion about this. And what I'd love to see is some of the medical experts, like Tony Fauci um, and Chuchat from the CDC and others who are really experts and have dealt with pandemics from Ebola to H1N1 a few years back. They're really experts who have experience and knowledge and could educate and really give advice to the community. Um, I think importantly, we need to hear scientific voices. We need to have people that are speaking the same language and that are experts at communicating with the public about these types of situations. I want to be careful that we don't inflame too much rhetoric around this. I think it's really critical that we give people good, sound advice. And at the moment, it feels a little discombobulated. And I think getting scientists and physicians and clinicians on the front line talking about this, I think, can be very helpful. And I encourage everyone to go um, to the UW websites and read about what they're doing there. I encourage you to go to CDC documents and see kind of what their recommendations are. I encourage everyone to go to their public health departments to learn what are recommendations that they're making, to be following the news as closely as you can, because I think that's really critical. So it's a good question. I'm sorry, I'm going to try to catch up with some of these here. Thanks for posting, Dave. Thanks for posting the IHME references. Liz Hinton Hill asks, if we've been isolated, never leaving the house, no one in, is there a point in time when we can visit others who have done the same? These are challenging questions. I think, if you've got friends and family that are doing that, I think it's okay to go and meet them out in the park and have a conversation. You can't live your life as a hermit, but I think one way to do that is you can if you want to start by doing it 6 feet away and having conversations, you can meet in public places. I've seen pictures of people driving up and opening the backs of their cars and all talking together but being still far away. I've had community members, they all pull out their chairs on their porch and they have conversations, but they're still a distance apart. So I think it's doable. I think what I would suggest is if you are going to meet people, one way to do it is to do it outside, walking in the fresh air, where air movement is a lot more, and instead of closed environments in households and restaurants and things like that, where the potential for transmission is higher. So we do want people to do as little of that as possible, because we really want to keep this at bay. But I think, meeting for a walk in the park and being able to stay some distance from each other, you can still have and meet up with people. I hope that helps a little bit in terms of addressing that. Janet Freeman Daly, thanks. A big fan as always. Like to see you here. How do you see this pandemic evolving in terms of identifying people with coronavirus immunity, developing herd immunity? Sorry, I got lost there. and reinfection from travelers coming into the country? Yeah, this is a really interesting question, I think. So I think the more people that get infected over time will lead to sort of more broad spectrum immunity. We don't know necessarily what that immunity means. We know likely in the short term that's probably protective. And uh, the um, the long-term benefit in terms of whether these antibodies will stay around or not, it's a little bit challenging to know for sure. So I'm not sure if um, um, the long-term um, antibody responses are going to be um, protective in the next season if COVID-19 continues to circulate. Um, our sense is that initially this is a good response, but we don't know what the cadence is going to look like and how quickly your antibody levels are going to decay. That's something we're going to have to find out over time. What's been interesting in terms of travel and people going around is that China, as an example, did a good job of managing this initially, but now there is additional cases that have existed that have come in from Italy and other locations. So I think there is the potential that there can be reintroductions into your community. So I think vigilance is important. A lot of the things that we're setting up in terms of testing and screening, they may go on for a while because I think there is still going to be this in the community. But as herd immunity gets better, it really decreases the ability of the virus to change, ability to the virus to interact and celebrate other people. So that's really really important to keep in mind that we have to remain vigilant about this. And I say this every year. I mean, my concept to all cancer patients in general is social distancing is important during respiratory virus season when there's flu and RSV. And so this may be something that we have to deal with for a while. It's unclear, and maybe it'll get better, over time. There's a lot of unanswered questions of what this is going to look like in the long term. But a good question I wish I had better answers to. See if I'm not missing a few questions here. I apologize if I am. Okay. Miriam Williamson is asking, can you describe the technical issues involved in testing? What is the feasibility of getting home testing going? Yeah, I think that's a really important question. So, in terms of the technical pieces of testing, there's a number that most of the swabs that have been approved for testing are these nasal pharyngeal swabs that have to go in your nose and kind of back to the back of your throat. They're actually hard to do for an individual to do the testing themselves. And I think what'll be really interesting is there are other swabs that are that are being approved, other techniques that are being approved. Some have documented that you could use saliva and gargling. There are others that have used just nasal swabs. So I think we'll learn more about that over time. Home testing at the moment has not been FDA approved. You can do testing. You can do self-testing where an individual can test themselves, but it has to be in a site of practice. I think that's going to change relatively soon. And home testing kits will be more available. I think the FDA has been a little bit cautious about this because there are a number of places that have been that have put out these kits that are unclear if they're of high value and they're very expensive. And so I think they're waiting for some more clear data to document that this is feasible and doable before they let this go out into the open market and let lots of people potentially cause issues with putting out tests that are not reliable. All right. So lots of questions here. This is great. I'm sorry if I'm not keeping up with everyone's questions. I'll do my best. Let me see where I am here. I'm just gonna choose a couple here. So sorry. Um, um, I think Akshata Prasad, FDA recently approved an antibody-based testing, which is much shorter turnaround time. How accurate will that be compared to real-time PCR-based testing? And also, with a recent past cold, I developed mild asthma. I'm at higher risk for getting infected. Am I at higher risk for getting infected with COVID-19? Yeah, so let me take the two portions. So the antibody test is different than, so what was recently FDA approved was an antibody test. There is also a PCR-based test by Abbott, which is a short turnaround time. It's about a 20-minute test for detecting the virus. So that's who's infected, acutely infected, versus those antibodies or something that you develop your immune response over time. So there's something that tell you previously been infected. So I think that short-term test is available in certain locations, but not everywhere. They've had limited supply of the reagents, and so they've been rolling that out in a couple of locations. I think in New York and Detroit and a few others. I'm not aware at the moment if Seattle has it, but we're looking carefully. And so I think that'll be something that's important. Once that's available, I think there's going to be lots of these assays that become more readily available. And in terms of your mild asthma, I think it's just watch carefully. If you start developing more shortness of breath or more pulmonary symptoms related to anything that you normally have, and if you have any of the symptoms of COVID-19, make sure you talk to somebody about it. I think it's really important to make sure that you talk to your physician and let them know if you have any symptoms that are related and whether they think you should get tested. And certainly if you have a really bad asthma flare, make sure you let somebody know. And let's say you do develop a really bad asthma flare and you've been having a little bit of a respiratory, infection for a couple of days, and you need to go get seen by a physician in a clinic or in the ER, call ahead and make sure they know that you had some cold symptoms beforehand so they can plan to take care of you appropriately. They can talk to you about whether they think you need COVID-19 testing and if it's available, and also potentially what they can do to protect the staff who might be taking care of you. Jamie Coleman asks a less serious question. I always like those. My dog addresses strangers and everyone wants to pet her. I do not have, I lost it there. Too many questions coming up here at once. I try not to have strangers touch her, but is she a potential vehicle for transmission? So first of all, let me just say I'm a huge pet fan. So Jamie, I'm jealous. My dog is awesome too, and I take her out for walks all the time. It's really important. Kind of keeps me going, and is a real source of comfort. So I think they're wonderful in these times when we have to do social isolation, and it's very frustrating from that perspective. I do think it's really important that if you have one of those longer leads, they can go up and somebody can pet them. It's fine as long as you maintain your distance is around 6 feet. One way to think about it, Jamie, for you is that we don't think dogs are a huge vehicle for transmission if somebody's been pet. But one thing you can always do is get some baby wipes. Just when they get home, just kind of quickly wipe them off on the top, just like a real quick surface wipe, and just make sure you really wash your hands very carefully. Whenever you're dealing with your dog, whenever you're going outside, I always have a lot of hand gel. I wash my hands frequently with soap and water when I come inside. And I think if you just wipe down the dog with a quick baby wipe, that can be a way to maybe make yourself feel a little better. And those are, if they're safe for babies, they're safe for dogs. So don't worry about that. And I don't think you have to go crazy. You don't need to give your dog a bath every time somebody touches them. But keep that in mind. That can be something that make you feel a little better. Sorry, I'm just going to see what other questions I got here. Jennifer, you had a comment. Let me see if I can get to this. Sorry, guys. Okay, I'm going to go to Kelly. You're very curious about giving blood. I'm a regular donor, was scheduled to donate platelets last Saturday. But on Friday night, I was notified that Bloodworks Northwest North Seattle Donation Center was closed due to lack of staffing. Should we try to give blood? And is it safe in light of that's hard to maintain 6-foot distancing? So I think there's two aspects to this. Is one, I do think you want to maintain 6-foot distancing if possible. If you're feeling fine, and it's also really important to donate blood. So we've worked through a couple of systems. I would really talk to the blood bank specifically about what recommendations they have. If you can't donate there, what might be other places you can go? As it spreads in our community, there are going to be more sick people out there. And so some staff at facilities are out because they're not feeling well and they're doing what's appropriate and staying home. But I think donations of blood or donating blood is important. A bunch of nursing staff from our side went out and donated blood recently. And so I think, I would talk to them. I think they're trying to protect their staff from people that are coming in as well. So they probably have policies in place. So I would talk to your blood center. I know that they're really interested in continuing the amount of blood that's available, because that has gone down as people have been worried going to blood donation sites. So check out just call BloodWorks Northwest and find out what would be the next steps that you would take. And if you can't donate there, do they have other suggestions about where you could donate? So Jenny Ross asks, how concerned do we need to be about the possibility that exposure does not confer immunity? What is the evidence in this case? Or another way to ask the question is, what's the evidence that exposure does confer immunity? Yeah, I think as we get more serology data, we're getting more information about this. You know, just thinking about this from the standpoint of most viruses, after exposure, you develop an appropriate immune response that is protective. And in most viruses, our immune system is really organized to prepare an immunologic response after a primary infection. So you've got this memory response that allows us to continue to prevent that infection from getting you again and again and again. Respiratory viruses are a little bit different, and I think what's challenging is that a lot of respiratory viruses are sort of the immune response is not quite as robust, or the viruses change each season a little bit, so that they learn how to evade the immune system. And in doing so, it's possible that we could get people get infected again. So I think the way to think about it is human coronaviruses, which are coronaviruses which are related in some fashion to the coronavirus that's out there, or ones that circulate in our community every year that cause, minor upper respiratory symptoms. They're related, but they're different. But they are seasonal, so you can get them multiple times. You don't get prolonged immunity that protects you forever. So I think that all the viruses are a little bit different, and the immune response to them can be different as well. So my expectation is that we'll probably have good, robust response for a season, and then it might change. My guess is that those memory cells will hopefully protect you if you get infected again from getting severe infection, but you might still develop upper respiratory tract infections. But it's hard to know. I think we need more time. We haven't had enough people that have had this infection for long enough to know whether it would protect you and for how long term. I think understanding that is going to be something that's really critical. Terry is asking about what are your thoughts about a mask now that the CDC protocol is reconsidering this? So yeah, this has been an interesting one that's been sort of back and forth. And I sort of would like a definitive statement. I think there's a lot of debate about what should be done in public spaces. I really want to encourage people not to buy surgical masks or medical grade masks, because those are really needed on the front line. We're really we want to make sure that that PPE and that's personal protective equipment is really in the hands of healthcare workers, because they need to be protected when they're trying to take care of sick patients that oftentimes are most at risk for getting infections. And I think it's really, really important to do to not be endangering that supply, which is already challenged. So I think what the CDC is going to be looking at, I think, is this sort of use of things like cloth masks and other approaches. I still think social distancing and hand washing are two most important. I'm not sure how much masks provide additional benefit, but some of the things they can provide, we do know, is that they can certainly help you from touching your face and your nose. Hopefully I haven't done that the entire time I'm here. I'm trying to train myself not to. And so if you have a device that can help you to prevent doing that when you're out in public places, I think that's an advantage. There may be some minor benefit in terms of, maybe a barrier to some exposure if you get some, but I don't think it's going to be massively different. So I think there is probably going to be a change, I think, in the policy. We'll see. But I think it's just important for people to not be using masks specifically as their only mode of protection. And I also think it's really important that people don't assume that because they're wearing a mask, they're protected. That's not true. And what I don't want to see is that people say, well, I'm wearing a mask, and so I'm sick, I'll go out in public and I won't get anybody infected. That's really, really, really important not to do. If you have symptoms, you should stay home. You should call your physician and find out if you should be tested. I think it's really important. I think if we don't do that, then we're really in trouble, because the masking policy can go the other direction. It could make it more comfortable for people to go out into public places, and I don't think these masks are that well organized to prevent transmission. So I think it's important to be careful. And remember that what masks really do is they don't necessarily protect you from getting infected as much as they provide a barrier for you to not infect others. And it really, I think the idea would be to help prevent any asymptomatic transmission. That's generally the concept that I think people are talking about. But I do really encourage people to be careful about going out and buying a bunch of supplies, and that assuming that the mask is sort of I use the term panacea, that's going to make you totally protected. I don't think that's true, and I think you have to be careful. Kimberly asks, we've heard that immunosuppressed are at higher risk, but does that mean for a 50-year-old on Humira for psoriasis, but is otherwise healthy? Yeah, Kimberly, this is an important question in the sense that there's immunosuppression is varied. What does it mean exactly? I have no clue amongst many of the different panoply of immunosuppressive agents. I think we're going to learn this as this rolls out over time. Certain immune suppressive therapies we know are going to be associated with risk. So people who go through bone marrow transplants, who develop complications, people that are getting treated with leukemia are likely going to be at high risk. And is there certain combinations of therapies that put you at high risk? Things that deplete things like your T cell function might increase your risk. So it really depends. We're not sure how much the TNF inhibitors might put you at risk. Something like infliximab or other agents that we're not sure. So people with inflammatory bowel disease taking these agents, people with rheumatoid arthritis, or those with rheumatologic conditions in general, it's really hard to know. So I think that's an emerging piece. I wish I knew answers. I think it will come as we have more of those cases because we have a lot of those therapies out there in the public, and I think you'll have more that are infected with those. But at the moment, I can't really be sure because I haven't seen data that's really been super helpful. So anyone who's getting any immunosuppressive agent, well, my typical recommendation is pretty similar. Is I say, try to avoid social spaces if you can, and that's true for anyone. If you have family members who are going out in public, have them go and avoid social, really do social distancing, washing their hands when they're coming home, and break open the video chats to talk to friends and family. Do walks in the park with your dog and the family in outdoor spaces. That's a great way to sort of continue to protect yourself as we learn more. And if you find out that it's otherwise begins to be more, there's emerging data that it's safer, then maybe that changes a little bit. But it's really important. I think people who get this can also be very sick when they're young. So even regardless of the immunosuppression piece, I think it's really important to the social distancing is really important to consider that it's not just about you, it's about who else you interact with. So transmission patterns are not only who you might become infected, but if you're infected and you don't know it, who could you infect when you're in public spaces? Or if you have mild symptoms and you don't think it's COVID-19, that you could pass this on to someone else. And my description for that is if you're going to the grocery store and you're picking up groceries and you interact with somebody who's in their 80s, you could potentially give them a life-threatening complication. Or if it's somebody who's otherwise healthy but has a family member at home who has cancer, it could really lead to complications that could be a risk. So I think social distancing has both things. It protects you, and it really, really helps to protect the community. Urania Gonzalez asked the questions, are immunosuppressed patients able to recover if they catch COVID-19? The answer is yes. We've seen some patients that have done okay. Not everybody who's immune suppressed has complications that are really severe. Some have really minor symptoms and recover quickly. So it's very different. It really is a broad spectrum, and it probably has to do with the type of immune suppression, your age, and your other comorbidities that you have. Chelsea asks, if you've already contracted and recovered from COVID-19, can you get it again? To our knowledge, there are sort of rumors that people can get reinfected, but we have not seen data to suggest that that's true. So I'm not convinced that that's true. It doesn't make sense from virology 101. So I think we'll have to wait and see. But my sense is, at least in the short term, the answer is no. that good immune responses would mean you would be protected against getting it again. Um, what we don't know is what the long-term response is it might be possible that you could get this again at another year, based on your antibodies waning over time. But we don't know the answer to that yet. It's a really important question that we're trying to get to the bottom of. And there's a bunch of people at Fred Hutch who are doing studies to try to better understand how we respond to this virus, both from an immunologic standpoint as well as an antibody response, and looking at things like the amount of virus we have in our systems. How quickly do we clear it? I mean, there's all kinds of important questions that are going to be critical. So I think lots of work that's going on in that direction. Um, I think, let me see here. Aaron, is there any information on the level of immunity after people recover? Again, similar question. I think what is immunity and what is protective immunity is still a component that's being worked out in a number of places that are doing these serologic studies. There's not really an ability to retest patients against getting re-exposure, but I think in general, people think that many of the people who have been exposed prior are protected. Some of the data suggesting that people get reinfected may just be the detection of um, virus by PCR. And remember, PCR detects components of the virus. It doesn't actually detect whether the virus is alive or dead. It's harder to do culture to see if people are positive, because cultures of this particular virus have to be done in what's called a BSL-3 lab. And that's where we take care of really highly contagious viruses. And there's a limited number of those around the country. So that kind of work needs to be done very cautiously. And so that's harder to do, to assess if those people who get reinfected are truly reinfected with a new case, or it's just leftover virus, or potentially a secondary exposure that the body has taken care of with its immune response, and that's just leftover pieces of the virus that are being detected. Hard question to answer, but I think we'll know more about that soon. Carol is a high-risk patient. She has lymphoma. Your daughter is, excuse me. She's a high-risk patient. She has lymphoma. She'll soon need stem cell transplants. She'll be using her own stem cells. Is it possible to still do the replacements when she's in remission? Hopefully 2 more months. I think, in the future, I think we're doing treatments for patients with cancer during all of this because it's important for life. People have life-threatening complications. If somebody really is in need of getting a transplant, we're pushing those forward. I think it's really important because that can be done. And I think it's really important that we sort of push this out to, really be thinking about how we're going to recover from this. What's the other side look like? And how can we give therapy to people after the major episodes are over, but it's still sort of circulating in our communities? So we're going to learn a lot about protecting patients, specifically about this. And over time, I think we're going to have more information about the best ways to organize these kind of approaches, and how to protect your daughter when she goes through this process. Our hope is that transplants will continue, and I think that we do believe that's the case. If by chance this is still ongoing and there's issues and that it's not felt that transplant is safe, the only reason that they would delay transplant is because they would have another option to continue her therapy to limit progression to something more severe. We're really moving people that need to have ongoing therapy because it's a life-threatening issue to active therapy, because we can't sort of wait to not give them something that might save their life just because of coronavirus. We need to protect them as best we can. So it's an important question that I think can be really challenging. Sorry, I'm moving here. There's some questions. Kevin Parker posted a question about hydrochloroquine as treatment. Have you heard of this, and can I verify it? So there's a bunch of protocols that are out there that people are trying. Hydrochloroquine, which is a drug called Plaquenil oftentimes. It's been used for rheumatoid arthritis and systemic lupus erythematosus. Erythematosus, SLE, or lupus, what many people know. The data is, there's been some encouraging data, some potential small studies that have suggested a benefit. Didier Raoult in France published a paper using both hydroxychloroquine and azithromycin. That's been widely talked about, and that suggests potentially a possibility. There's been some debate about how the study was organized. I'm not going to get into those components of it, but I think it does suggest that there could potentially be a benefit. But really, the way to answer these questions is to do randomized clinical trials and to better understand whether it's beneficial or not. And there's a group here at University of Washington that is doing a study specifically to evaluate this, run by Ruan Barnabas. And Ruan developed a protocol that that we can get people in that have either been exposed to coronavirus or people that have been diagnosed, and to try to figure out if we can limit, excuse me, we can limit the ability for the virus to replicate and potentially provide benefits to people who might be exposed to COVID-19. We don't know yet, and I think those studies are going to be critical. They have to be pretty large size, and there's another one at the University of Minnesota that's being done this way. So I think it's really, really important that we really look to more science on this and more randomized controlled studies, which we can assess whether this really does provide a benefit. There are, hydrochloroquine's been used and discussed as a antiviral and other things like flu. It was used as a prophylaxis and it didn't work. But that doesn't mean it won't work here. I just don't think we know enough about it. So I certainly would recommend if people want to enroll in a trial, sure. And if your doctor feels like you would benefit from it, go for it. I think it's important to talk to your physician about it. I think not all of the situations do we know that it's necessarily effective, and I think we need randomized trials to better understand it. So that is ongoing. The WHO is also doing a really large trial with multiple different agents to see if it's beneficial. I think one example that I've used a couple times is there's a drug called Kaletra, which is an HIV drug that looked in vivo, meaning in an animal study, looked really good. And they started using it in patients in a randomized clinical trial, demonstrated that there was no benefit. So we don't want to spend money on therapies that are not effective. I think everybody wants a treatment that's effective. I think there are some things out there that look promising. There's remdesivir, which is made by Gilead, which is in clinical trials that's been enrolling very quickly. We'd love to see some early preliminary data to suggest that might be beneficial. There are other drugs that are in the pipeline that look interesting, and convalescent sera has been discussed. So I don't know what the right therapy cocktail that's going to work the best, and I think doing randomized clinical trials for hydroxychloroquine is going to be important, and that's coming. I think that data will be coming along soon, and I hope that'll help us to decide whether or not this is the right approach. How effective, and Dickie was asking about how effective is remdesivir, ritonavir, chloroquine for hospitalized patients? Are those medications available in every hospital? So hydroxychloroquine is pretty available, I think, in most places. Remdesivir is a little bit more limited. They do have a protocol open for compassionate use in certain areas, and certain hospitals have an NIH open, excuse me, an NIH trial that is open that people can enroll in to be treated for specific manifestations of the disease, and that's open at University of Washington and many other locations around the country. So we don't know the data yet. There's been some trials that have been done see, I just touched my face there. That have been done in China, but we haven't seen those results yet. I think we're all waiting to see some additional data. I think there's a lot of optimism that there could be benefits there, but I think we're just waiting to see. The ritonavir and a combination, which was the drug called Kaletra, has not been effective, and the chloroquine data is pretty minimal yet, but I think we just need more added to the mix, and I think a randomized clinical trial is going to be really important. Okay. When will tests be available to see if we've been exposed? How can I be reinfected can I be reinfected again? I sort of mentioned this beforehand, but this is by Elizabeth Stewart. When will the tests be available to check when we see they've been infected? So again, it's antibody testing. Those are coming. There's just been one approved by the FDA. So I think those are going to be moving. We don't really know whether we can be reinfected. We think it's probably less likely, but that data is still out there because we haven't had it long enough to know. I'm going to try to answer a few more of these because we're kind of got about 5 minutes left. Um, let's see. Zach is asking how and when do you see us returning to normal life without flaring up a new wave of COVID infection? As I mentioned, if you hear my cough here, as I'm kind of having that a little bit, I've been tested for COVID-19 and I'm negative. Um, so that's important. If I had a cough, I went and talked to my provider, got tested, and I don't have it. But I'm social distancing because I have symptoms, because I don't want to make sure I don't get anyone infected. So that's important. I'm following my own guidance. So Zach, really, it's hard to predict for sure, but I think some people feel like June is a point in time when we'd start to see some periods of being able to lighten the load. How we do that is hard. How do you get out of this situation where everyone's been in social isolation? We don't want to see that second wave. I think, we need to be cautious. We need some of these serologic assays will really help us where we can identify who's been infected, excuse me, and who hasn't. Um, it's really critical to understand that piece. And I think as we're waiting in our homes and places of work and doing social distancing, I think that's going to help to know how we get people back to work and how we get people back out in public and how we reopen. There's no question we're going to have to. It's just a matter of when and when that's appropriate. And I'm really one who follows my colleagues who work on mathematical modeling, who look at disease epidemiology, and our public health people to help us identify the best timeframes. I want to be cautious about sort of making any long-term predictions, but I just don't know. I think it's probably going to be June or sometime around that time. That would be my best guess. But it may be later in May we start seeing some looser restrictions. It'll be interesting. I don't know the specific details, but Zach, thanks for asking. Erica is asking, how safe is it to go get groceries? Well, you have to. You have to live your life. You have to eat. So I think, you can go get your groceries. I think you can maintain 6 feet distance. You can fill your bag and, buy your groceries at the counter. I usually recommend that you use the self-checkout line if you can, if that's possible. That helps with social distancing again. And there's also options for a lot of places that are delivering groceries to your home. So some of the grocery companies you can actually organize and purchase ahead of time. It is interesting how they're now organizing so you can go pick up your bags. They'll have them packed. You open your trunk of your car and they'll put them in for you. So companies are coming up with interesting ways to deal with this, which I think is great. I think that's what our communities are all about. They're trying to solve these problems so they can continue to provide support for people. So you need to eat. You need to have good nutrition. It's important things to prevent you from getting complications. So eating well, hydrating well, getting some exercise, and getting a good amount of sleep. It's a little hard for those working on coronavirus, but I think it can be a helpful way for you to maintain your protection. Layla Bush is commenting that she needs a prescription for hydrochloroquine for her rheumatoid arthritis, and just is cautioning people not to load up on this. And I absolutely agree, Layla. Thanks you for bringing up that conversation. I'm concerned that as hydrochloroquine is being promoted as the therapy of choice, when we don't have randomized trials to promote it or to prove that that's the case, I think there's some encouraging data. We'd like to prove that that's true. Um, I'm a little worried that as people use it and buy it, even getting their doctors to give them an advanced prescription, the danger is we're going to be taken out of the hands of people who really need it. Um, I have a relative that has lupus, and it's really hard when they're concerned that they may not have stock. So if you're a patient that has lupus or rheumatoid arthritis and you need it, talk to your pharmacy and make sure they have stock for you available, and make sure you get at least 3 months stock that you can have at home, because you are someone who gets it for the reasons that are important, because you don't want to be in a situation where you run out. And you might talk to your physician about, is there another alternate therapy that could be potentially available. So I think I've got a few minutes left here, about seconds left before it's the end of the hour and I have to go off and do more work. I think I'm not sure I can answer any of these questions quickly. I appreciate everybody saying that this was helpful. I hope it is. I can't answer all these questions because there's still so much out there about this disease that we don't know. But places like Fred Hutch and University of Washington are really doing a lot of work to get research to better understand how we can be prepared to reopen economies and reopen communities so we can get out there again, and also best ways that we can treat and diagnose patients. You know, I mentioned beforehand, my colleagues at UW Virology are an example of how we've been able to do this really well. Keith Jerome, who's a director, who's a faculty member at Fred Hutch, they really developed one of the first, I think the first commercial assay available here in the United States that was approved by the FDA. And it has been a huge, huge factor for us to be able to address this in a really thoughtful way. We have much more access to testing. We have the ability to know who's infected and not. It is incredibly important, and we need to get more testing out into communities all over the country. So testing is a critical piece to that. I want to encourage all of you to continue social distancing, keep looking for serology studies because those are going to be valuable. And I just want to thank everybody for your time and listening. I hope it was helpful, and best of luck out there. Stay safe, stay home, and please wash your hands on a regular basis. And hopefully we'll see you guys soon. Thanks.